Samir Khleif. I'm the director of the Cancer Center at the Georgia Health Sciences University, and I'm a speaker at the 27th annual meeting for the SITC. I'm participating in a session which addresses the critical issues for clinical trials in immune therapy. The issue of immune therapy, of course, is that we know more about how it works now and the mechanism and the biology behind the way that the immune therapy works. We in the field are trying now, of course, in clinical trials, to define how clinical trial design should be implemented in immune therapy in general. And particularly when we talk about those generalities of differences in implementation, we need to talk about what is importance about the responses or the response rate or the design itself or the patient population, etc. So this session is going to be actually focusing on areas that would define those challenges in immune therapy, clinical trial design, and how do we put those designs to action for the 21st century in developing this fourth modality of cancer therapy. The two areas that we're trying to actually focus on is one, the early clinical trial design. Is it the same as chemotherapy or it's different than chemotherapy? And since now we know that it should be different, what is it required for those clinical trial design in early stages of development of the drug that would be needed to take the drug into late stage of development, phase 3s, or the market? What are the issues that are similar or different than chemotherapy? And how do we think about designing those early clinical trials? Particularly that at the end, those immune therapies are not going to be working by themselves as one modality or one drug such as a chemotherapy. They have to be working in multiple combination with other immune modulators, because at the end, when we try to influence the immune system to function or work against the tumor, we're working on all the tumor immune modulating network, which is a vast network. So accordingly, there are multiple areas that need to be hit. So we come back to early development and the responses in early development. What do we take as measures of working or not working, one? And second, if we're going to start combining those different drugs together, how do we design trials to be efficient and in a way cost effective? Because when we start thinking of the different combinations, whether in blocking antibody for co-inhibitory molecules or neutralizing antibody for inhibitory cytokines or affecting specific suppressive cells, such as T regulatory cells or MDSCs. So if we think of that multiple or different modality therapy, particularly if it's combined with vaccine, there are multiple of those A, B, C, D drugs. So what do we do for early development in those drugs, and how do we design them in a way that we don't have to go through phase 1s every single time for those combinations that might take years and millions of dollars?